on depression, Exemplar 28A. I did record it, and somehow I messed up when I was trying to upload it, so I'm going to record it for a second time. So the depression module starts page 1932. It's just extending on from our mood and affect. Depression is a disorder characterized by a sad mood or loss of interest in usual activities, lack of energy, sleep disturbance, anxiety, anxious distress, abnormal eating patterns, psychomotor retardation or agitation, feeling of despair, guilt, or hopelessness. They don't have to have every one of those, but those are common characteristics. And about 16 million Americans have suffered from a major depressive episode each year. And most, where did I see it? It was like 20 to 40% is all that actually gets treatment. There are multiple theories for depression, but they really believe it's all interacted. The biological include genetics, chemicals in the brain structure, or biological rhythms like our circadian cycle, hormonal factors such as cortisol levels, inflammations, biomarkers that come from your cytokines. You have your interpersonal, which is your inborn need for relationship and security, reciprocal relationship between depression and interpersonal problems. The learning theory is learned helplessness, perceive themselves an inability to control their life. They have repeated failures. Cognitive theory is internal thought processes influence mood. In those with a mood disorder, they characteristically have negative thinking or a skewed view of the world. Sociocultural role of social stressors, poverty, job insecurity, disruption in family system, emotional exhaustion, holiday time, history of child sexual abuse, different things, diversity, which is listed on page 1917, back in your major concept. Up at the top right corner, focus on diversity and culture, influence of culture and gender on depressive disorders. Just look over that. Okay, so prevalence. Major depressive disorder is more common in women than in men. Major depressive disorder, bipolar disorder, more common in women than in men. Of course, postpartum depression has to be women, but it affects 3 to 6% of women. Suicide, more men, 4 times more men than women. It's the 10th leading cause of death. There's non-modifiable risk factors such as genetics and neurobiology and heredity, with the family history increases the risk of having major depressive disorder or some kind of depressive disorder. And you can see that back on page 1917. It has a little wheel in figure 28.2. Let's see if there's anything on the next page. Not really. Okay, keep going. So, oops, went too far. Major depressive disorder, change in emotional state and functioning lasting 2 weeks or longer. Usually occurs gradually. They don't have mania or hypomania. They're not extremely energetic or under like hypomania. They have anhedonia, which is that lack of joy, insomnia or hypersomnia, like they're sleeping too much or they can't sleep. Psychomotor retardation or agitation as they're revved up or revved down. 1934, let's see, box 28.2 on the top of page 1934 are the symptoms: low self-esteem, feelings of worthlessness, sadness, crying, significant distress, aches and pains. That's that psychosomatic symptoms that can go with it. It can be episodic and can be repeated, like it comes and goes. It progresses from mild depression and anxiety to significant. They could have suicidal thoughts, feelings of guilt, worthlessness, impaired concentration, inability to make decisions. Then you have your persistent depressive disorder, formerly called dysthymia or chronic depression. I still hear people refer to it as that, but they've now changed it to persistent depressive disorder on page 1935 of your text. Less severe but longer lasting form of major depression. There will be no more than 2 months in the past 2 years that they are symptom free. So this is a long time. You're talking a 2-year span with maybe, here it goes here, for at least 2 years and at least 1 year in children and adolescents with depressed mood that occurs for most of the days, for more days than not. And the text says no more than 2 months out of that 2-year period where they don't have this depressed feeling. Persistent. Often occurs in childhood and adolescence, early adulthood, boys and girls at the same rate, and things that impede their outcomes are comorbid anxiety or a conduct disorder, severity of symptoms, and how impaired in functioning they are. I picked this slide because I love Eeyore. I just feel sorry for that guy. And Mother's Day, my son and daughter-in-law actually just got me a mug of Eeyore because they know I love Eeyore. Okay. So that's that persistent, if you know Eeyore, that persistent depressive disorder, picture him. Okay, so seasonal affective disorder. There's not a specific diagnosis, DSM diagnosis. If you see DSM written things, that is your Diagnostic and Statistical Manual of Mental Disorders. So the DSM-5 is the 5th edition, and I don't know if they're still on the 5th edition, but that's the Mental Disorders Diagnosis Guide. So seasonal affective disorder is not listed in there as a specific disorder. It's actually classified as a major depressive disorder with seasonal pattern. So it occurs during, as things die, the mood dies. As things come alive, the mood comes alive. Most at risk are females, younger people, and if there's a personal or family history of depression or bipolar. It's triggered by less exposure to light because there's actually SIRT, which is a protein that binds to your serotonin. The SIRT is suppressed by sunlight. So with less sunlight, the SIRT applies itself and binds with the serotonin. So it decreases the serotonin activity and leads to this depression. Also, elevated melatonin levels are found with people with seasonal affective disorder. Oh, why do I keep skipping slides here? Adjustment disorder with a depressed mood. On page 1935 into 1936, this is called situational depression. It's an adjustment disorder. They did not adjust well to their situation. It usually follows a stressor within 3 months after the event and typically lasts no more than 6 months. It could be some catastrophe and you've gone into a depression, and within 5-6 months you come back out of it, but it was because you were having difficulty adjusting to that situation. If they have pre-existing mental health issues or unhealthy coping mechanisms, they are at greater risk for having an adjustment disorder with depressed mood. It is important to distinguish between grief and depression. There is a table 28.2 on the top of page 1937 that does a clear distinction between the two. with the trigger, active, passive, emotions, ability to laugh, activity, self-esteem, and feeling of failure. So with depression, there may or may not be a trigger. They tend to be very passive and not pull themselves out of this. Their emotions are hopelessness, helplessness. They're unlikely to laugh or allow anybody to try to bring them out of this mood. They lose interest in things they used to enjoy doing, activities. Low self-esteem, feeling like they're a failure, dwell on past failures. That is depression. And the difference with grief is there is a specific trigger. They are not passive, they're actively expressing this loss, this grief, these feelings they're experiencing. Emotions can be anywhere, up and down, but very intense as they're dealing with this loss. Ability to laugh. They sometimes will be able to laugh and enjoy humor, more likely to accept support. My mother died in November, and that night my brothers and my sister and I stayed up most of the night just talking and laughing and sharing stories and sharing tears. That is grief. Activities can be persuaded to participate in activities. They're not withdrawn from the world. They may be sad, but they could still try to get up and move. Self-esteem usually remains intact. They don't feel like a failure. Feelings of failure, if there's any self-blame or guilt related to it, as they heal emotionally, that passes too. So the difference between grief versus depression. Collaboration, page 1928, 1929, 1937. So page 1937 is here in this exemplar, and going back to 1928 and 29, I said we would be coming back to those. So the diagnostic testing is looking for anything else that may be causing this, aggravating it, contributing to it, like they had MI, low oxygen levels, their liver enzymes are high, so they have ammonia in the brain. After MI, depression is common, a heart attack, myocardial infarction, are they anemic? Is their B12 low? Multiple things with affecting, is it some outside cause or aggravating cause? Pharmacological therapy, there are multiple drugs that are listed, and we will, the page 1927, I'm going to come back to those a few slides from now. Psychotherapy, the main one your text talks about, which is very common, is your cognitive behavior therapy. It's non-pharmacological. CBT, it talks about it on page 1928. CBT is using mindfulness, art of conscious living, focusing on now. It's used quite often. Nurses can even use it in multiple factors, especially with teaching. I used cognitive behavior therapy as part of my doctorate project on dealing with health and obesity in rural areas. And so I was using cognitive therapy by asking people questions about themselves and bringing an awareness to the choices they were making in their life, and having them explore different factors that caused these decisions, to bring an awareness, or as this refers to, mindfulness, and they could then start to change their behaviors as they became aware and took control of them. Cognitive behavior therapy. ECT is electroconvulsive therapy. Sorry, that got stuck on my tongue. They put leads on one side or both sides of the brain to cause a seizure. They pass through the brain. It's done under anesthesia. You have to have an informed consent. The magnetic pulse therapy is not as invasive, and I've got some slides, and we're going to talk a little more about those. There's acupuncture therapy, which can be used in conjunction with with antidepressants and medications, pharmacological therapy. Did I skip another slide? Gosh, I don't know why this thing is doing that. Okay, so electrical convulsive therapy, back to here. There's patient teaching on page 1929. Be familiar with this. You have to have this is anesthesia. They will put in airway, even though it does not last for a long time, 2 to 3 minutes, but they have to have a bite block and the airway managed because they're put under anesthesia, so their muscles relax. They are given a muscle relaxer because they will go into seizures, and you don't want them biting their tongue or hurting themselves. You have to have IV access. Has to be an informed consent. You are, as a nurse, are witnessing their signature on the consent. You are not to do the education. When you look at a patient teaching, it sounds like it says you're going to teach the patient about this. You need to know that they have an awareness of it, but you're not the main teacher of it. Empty their bladder before the procedure. You're monitoring vital signs, oxygenation, because they will give a muscle relaxer, succinylcholine, and succinylcholine will paralyze them. So that's why anesthesia is maintaining their airway. They will have some confusion and memory loss. It's usually short term, but sometimes some of that can be permanent. What else do you need to know? Just a general anesthesia. Afterwards, while they're waking up, you're going to put them in a lateral recumbent, which is a side-lying position to help with so they don't aspirate. Once they're stable, they can leave, but they cannot drive home because they have been given anesthesia. This magnetic pulse, there's just a little section here. It's called on page 1929, transcranial magnetic stimulation. It's done with magnets. Short pulses of magnetic energy. It can have a rapid onset within 1 to 2 weeks, which is faster than psychotropic meds, with less adverse effects such as the cognition memory loss. Unfortunately, the effects don't last as long or bring as much benefit as the electroconvulsive therapy does. Acupuncture came back to there. I don't know why my slides got messed up. And it enhances the therapeutic response to SSRIs, which are the medications I'm going to go over, and it can lead to decreased adverse or side effects of those medications. So, your pharmacological therapy, so your look at your page 1927 in your text. We have SSRIs. I gave you the page numbers in your drug handbook. If you want to look up more, I'm going to tell you where to focus on these. So your SSRIs, SNRIs, TCAs, and MAO inhibitors. Those are the 4 classes for treating depression. SSRIs, selective serotonin reuptake inhibitors. So tries to keep more serotonin available for your body to use to help with your mood. Your, let's see, the ones they have listed here, yes, citalopram, which is Celexa, escitalopram, which is Lexapro, fluoxetine, which is, fluoxetine is Prozac, paroxetine, which you may know as Paxil, sertraline, Zoloft, and don't worry about the last one. Those are the ones most common, and you can see it's a pram or an ene ending. Citalopram and escitalopram, I call them cousins. It's the first, escitalopram was the second line after citalopram. Most of these you will tell them to take in the morning. Your fluoxetine and paroxetine, which is your Prozac and Paxil, you definitely want them to take in the morning because of increased energy, especially your fluoxetine. It's the one that's the most energizing of them. Your other citalopram, escitalopram, may cause some drowsiness, so some people do better taking it at night. Sertraline or Zoloft, most people do take that at night. But I think your text tells you to have them take it in the morning. But that's my take on it. They are used for depression, also can be used for the SSRIs for anxiety and eating disorders. Nursing considerations, do not take with St. John's wort or ginkgo biloba because of the increased serotonin, increased risk of serotonin syndrome, which we will talk about. All of these SSRIs should be taken with food. Any of antidepressant medications all can increase the risk of suicidal thoughts, ideation, especially in the teenagers to early 20s is the highest risk. So you make people aware of this and that the dose has to increase gradually. It's going to be about 4 weeks before they see on any of these medicines we're going to talk about 4 weeks to see any effectiveness or the full effectiveness of the medicine. So within the first couple of weeks, they may not feel anything or not the full effects. So that's why the dose adjustment is done slowly, because it has to build up to these effects as it's helping your serotonin not be blocked out. What else? Ask them about suicide. They need to report it immediately. Never stop any of these medicines we're going to talk about abruptly because of there's withdrawal symptoms that are pretty terrible. Okay, that's what you need to know on SSRIs. So here I have your SNRIs and your tricyclics or TCAs. Your serotonin norepinephrine reuptake inhibitors block the uptake of both serotonin and norepinephrine, making them both more available to the body. The tricyclics also do that, plus there's a receptor blockade with your muscarinic receptors, and I'm going to go into that in just a minute. Let's stick to this side over here with your SNRIs, or serotonin norepinephrine reuptake inhibitors. That norepinephrine piece goes into your nervous system so that's why can be used to treat neuropathic pain, in addition to depression, because the depression deals with the serotonin, and then your norepinephrine deals with that neurological system that we talked about. So that's why it helps with your neuropathic pain. Okay, so SNRIs, which ones do I want you to be familiar with? There's desvenlafaxine, duloxetine, and venlafaxine. Now you notice 2 of them begin with laflexin at the end. Desvenlafaxine and venlafaxine, which is Pristiq and Effexor. And then the other duloxetine, not far off from the sound of Exene, it's Exetine, which is your Cymbalta. Those are the 3 SNRIs to be familiar with. Because of that norepinephrine, and then over here your muscarinic more so, your SNRIs, because of the norepinephrine effect, some side effects, common side effects are nausea, dry mouth, constipation, drowsiness, and insomnia. Nausea, dry mouth, constipation, drowsiness, and insomnia. On here in your text on 1927, SNRIs should be used with caution in patients with seizure disorders. Both things on this chart, your TCAs and SNRIs, both decrease your seizure threshold. Everybody has a seizure threshold. People with a history of epilepsy or seizures have a lower seizure threshold, is why they are more prone to seizures. So if you're taking a medication that's going to decrease that level even more, when you're already at risk, there's a high risk for seizures. So it's used with caution, possibly questions, not totally contraindicated, but you want to evaluate and ask about that and let the person be aware to report if it causes seizures, because they need to probably change the course of medications. The other on SNRIs, they are at risk for hepatotoxicity, that's your liver, and they can have some orthostatic hypotension, so changing positions slowly. Now we get over here to the tricyclic antidepressant sides, and some of the side effects correlate a lot because of blocking that reuptake of your norepinephrine and your serotonin to make it available. Muscarinic receptors. If you look back at your slides on your autonomic nervous system, on your parasympathetic side or your cholinergic side, you have the muscarinic and your nicotinic receptors. So seeing this triggers that, oh my goodness, we're looking at the parasympathetic or cholinergic. So if it's an anticholinergic, because it blocks parasympathetic side, you're going to have anticholinergic symptoms of I cannot see, cannot eat, cannot pee, cannot poop. Blurred vision, dry mouth, urinary retention, constipation. Some of those same things that you were seeing over here on the SNRI because of the norepinephrine block. Okay, the others here with tricyclics are contraindicated if they have narrow angle glaucoma. All anticholinergics, things that block the cholinergic or parasympathetic nervous system, are contraindicated with narrow angle glaucoma, and if they have prosthetic hypertrophy, which you guys, I think we study soon. Sometime this semester, you'll get into BPH, benign prosthetic hypertrophy, which is this benign enlargement of the prostate gland. And if you remember your anatomy, that prostate is sitting there just above the rectum, and if it gets enlarged, it's pushing up on the bladder and blocking that emptying, so they don't have a full emptying of the bladder, frequency, urgency, and inability, so they have urinary retention. And so if you have BPH, you have an increased risk. So if somebody already has urinary retention, that is caution, and narrow angle glaucoma is totally contraindicated. Oh, I forgot your text TCAs. Here it has tricyclics may cause decreased sweating along with anticholinergic side effects. I say can't see, can't eat, can't pee, and increased heart rate, all listed there. TCAs are contraindicated if they've had a recent heart attack, myocardial infarction. The same thing I told you with SNRIs, TCAs on your seizure threshold and caution, contraindicated, or used with extreme caution in urinary retention, prosthetic hypertrophy, contraindicated if they have narrow angle glaucoma. So your TCAs to be familiar with, tricyclics, are your amitriptyline and your nortriptyline. Those are the two I want you to focus on there. Notice your TCAs can also be used for anxiety neuropathy, again because of that norepinephrine right there. Okay, so the last, serotonin syndrome, let's talk about that. Rapid onset with a combination of 2 or more serotonin agonists. So if you have things that are stopping the reuptake, making the serotonin more available, serotonin agonists, there are multiple things that can be added in for sleep and other things. They might be on amitriptyline along with something else. So that combination puts them more at risk for the serotonin syndrome, just like the St. John's wort and ginkgo biloba will do, because they increase the serotonin available in your body. What is serotonin syndrome? It mental status changes, agitation and pressured speech, autonomic instability. It's affecting your autonomic nervous system, your fight or flight. It's stimulating it. So you have increased heart rate, increase in the gut. So you can have diarrhea. You can have shivering because everything is sped up. Diaphoresis, so you're shivering and sweating. Mydriasis is where your eyes, pupils are dilated, the fight or flight. Autonomic nervous system is triggered. Neuromuscular abnormalities, you can have clonus, the muscles are tight, they can possibly seize, tremors, and their reflexes are very hyper, especially in the lower extremities. It is treated with a benzodiazepine, which of course we have not studied yet. Benzodiazepines are like your diazepam, clonazepam, which is clonidine and Valium, your Xanax. Oh, I just went blank on alprazolam. So your benzos end in that pram. Okay, hydration, cooling, because this tachycardia, shivering, diaphoresis, everything you can do with cooling. That's all you need to know on serotonin syndrome. And just making the patient, that's part of your teaching, is the risk of serotonin syndrome, what it looks like, to educate them. And they can go into that too when they're stop things abruptly. They get a lot of muscle twitching and nerves and numbness down the arms. Okay, so MAO inhibitors. The ones I want you to know are two. You have your Seleglene, which is a topical patch. The other one is your Nardil, that's the brand name. Your generic name is phenelzine. Phenelcine, I think. So phenelzine is common. I've seen it in Kaplan. I've seen it in NCLEX reviews. So Nardil or phenelzine, and then your topical or transdermal patch of Seleglene are the MAO inhibitors. You need to be aware of those names. MAO inhibitors are, as your text tells you, monoamine oxidase inhibitors. They inhibit that enzyme that terminates the action of neurotransmitters such as your dopamine, norepinephrine, epinephrine, and serotonin. Interacts with lots of foods and medications. The big thing with them is the foods. No cheese, wine, or pickled foods when they're on MAO inhibitors. If they do take this, they will have sweating, tremors, dizziness, extreme hypertension, and pounding fast heart rate. It can be an emergency, and you have to not take any cheese, wine, or pickled foods while on MAO inhibitor and for 14 days after coming off. And also these tricyclics, barbiturates, antihistamines, CNF depressants, over-the-counter cold medicines, antihypertensives, you cannot take those if you are on MAO inhibitors. And again, that 14-day span between these and this, between this and this, whether coming off of this and going on that, you need 14 days in between, and the same the other way around. MAO inhibitors potentiate hypoglycemic effects, which you will be studying the diabetes and those drugs this semester. So it potentiates, so it makes your hypoglycemic drugs and insulin work better, lowering your blood sugar more. So that is a risk of interaction between MAO inhibitors and your hypoglycemic medications, anti-diabetic drugs. When I say here about this elevated blood pressure, extremely elevated as a hypertensive crisis, and I said this can be a life-threatening emergency. Okay, that's it on MAO inhibitors. Lifespan considerations. Depressive orders in children and adolescents. So be a little familiar, this is page 1937 in your text, of how it presents in children and adolescents. It varies by their age. Depression is expressed in toddlers with regression. It's expressed in preschoolers through self-destructive play. Then when you get to school age and adolescent, they usually have things like an impairment in their or decrease in their academic performance and a lack of involvement with prior activities. Depressive disorders in older adults, when they have Two stressors close together in time increases their risk of a depressive disorder. There's a geriatric depression scale that's right here on this page, here on this slide. And to scales here, if they have 5 yeses, it indicates depression. These things, depression or any of these symptoms, are not part of aging. There's no reason to and they don't have to be depressed. It's not screened for enough. It should be screened, evaluated, and managed. So that is the geriatric depression scale. Nursing process: observation, patient interview, physical exam, suicidal assessment. Page 1938 in your text, and that is exactly what I covered on the just previous lecture on the whole concept. Let me see anything else here. Diagnosis. So we're doing the nursing process. Your ADPI: assess, diagnose, plan, implement, evaluate. ADPI. So you assess, you observe, you get patient interview, do physical exam, and do a suicidal assessment. Box 28.3 on page 1939, physical complaints and depression. It is common to have different aches, pains, joint pains, headache, changes in appetite, sleep. So just look over that. And again, stress, suicidal assessment needs to happen by asking them if they have any suicidal thoughts, ideas, ideation. Have they tried before? Are they thinking about it? Do they have a plan? You are not putting the idea in the head. You need to ask this, and you need to document the response. If they have a plan, they are considered immediate risk. Suicidal risk is the one time when confidentiality does not apply. If they are risk to themselves or others, it is mandatory reporting. Okay, so we get to diagnosis. There's multiple diagnoses here. They're also listed in your text. Can be your nursing diagnosis to help with your planning. So you assess, you make 1 or 2 or 3 multiple diagnoses, and then make a plan of what you want to do or happen related to what you have chosen as your priority diagnosis for this patient. So you're planning, those are examples of possible planning. Do necessary daily self-care, normal activities, meaningful social interactions, verbally healthy lifestyles. There's your cognitive there. So these multiple things that you hope to achieve. So now you have to go, okay, that's what I'm hoping for. So how do I go about getting it? So you make your implementation specific to the diagnosis. You get a diagnosis. This is what I want to happen. How am I going to make that happen with implementation? Make sure it flows all the way across your steps. These are some things that the nurse needs to be aware of. Being emotionally neutral. You may have to ask for a temporary reassignment if it's emotionally becoming too difficult. You always want to instill hope, not unrealistic hope. That's where we come with our outcomes. The patient will not feel suicidal, free from vegetative symptoms. These are possibilities that your text listed for possible outcome evaluations. Remember, your outcomes are your SMART goals: specific, measurable, achievable, realistic, and a time frame. So make these planning and evaluations specific and measurable. On the care plan that I gave you guys, I have short-term and long-term. So some of these may be short-term and some of these may be long-term outcomes. Look on page 1940. There is a patient teaching on increasing self-esteem. It also gives you some ideas on your implementation of how to achieve some of these things. And there's a really good care plan here. It shows you how to take things across on all your steps. Okay, so that is the end of this recording, and hopefully I can upload it correctly.